This episode is dedicated to the memory of Erica Weber. Her dedication, kindness, and commitment to patients and friends was instrumental to the creation of the Recovery Center.
Welcome back to part 2 of our discussion today with Eric Haram from York Hospital's Recovery Center. This is a continuation from part 1 that we had last episode with Dr. Christine Monroe and Eric, where we introduced our listeners to the Recovery Center and what it does here for our patients at York Hospital. I'm looking forward to part 2, Kate.
I am too. So we'll get right into it and
Let's go
from there.
Let's do it.
Hi, I'm Kate Ford.
And I'm Eric Fogg.
Welcome to Seatown. In each episode, we will discuss all things York Hospital, past, present, and future, as well as current medical topics to help us navigate that sometimes confusing world of healthcare. So we talked about wanting to do a little bit of shout out to our community partners or people we're collaborating with out in the community. And so do you want to talk a little bit about that, your partnerships?
Sure. When we think about substance use, misuse and substance use disorders in our communities, there's a whole host of different groups, champions, and organizations that, particularly here in the York region, are coming together in a much more orchestrated and thoughtful way. And so I want to particularly mention the Choose to Be Healthy Coalition. Sally Mannanen, who works here at York Hospital, and her colleagues that do a lot of organizing with local law enforcement, food, housing assistance programs, childcare, and the schools, local law enforcement. And we've been able to really pull that together into what we call the Opiate Roundtable, which is a group of all of those individuals that meet on a regular basis throughout the year. This has been going on for a number of years now. And when you put all of those different service providers and organizations together, what you really have is the full continuum of what we call primary, secondary, and tertiary prevention, right? Early identification, enrichment programs to shift the chances that young people will begin using or misusing substances, all the way through to what we do, tertiary prevention, which is really the delivery of treatment once someone has acquired a chronic condition like a substance use disorder. And I don't think we always see that full stream of all of those services and how they come together for our communities. And just wanted to make sure to try to paint that picture for folks.
Yeah, Sally and her team do a great job. I know Gina Brodsky also on her team works with the high school with the Tidal Waves group and that. So it's important work that they're doing as well. So we want to talk about kind of the wording around, I know we've moved from substance abuse to substance use, and then kind of bring it right into defining MAT a little bit more and how that's even evolved. So can you start with that?
We talked in the last episode a little bit about stigma. I mentioned the work the hospital has done, particularly around destigmatizing substance use, misuse, and substance use disorders. And we've done a lot of that in the community as well. When we think about a problem with substance use, nobody wakes up one morning and thinks to themselves, gosh, I really would like to have a substance use problem, that kind of a chronic illness and require care and treatment for that. It's something that is acquired subtly over time. There are genetic factors, there are social factors, there are life circumstance risk factors that increase the prevalence or potential for a person to have a substance use problem. The language we use really keeps such a prevalent chronic illness in the shadows. And those are things like, she's an addict. Or he's an addict. versus this is someone with a chronic medical condition or a substance use disorder. As treaters, we've contributed to that with some of our language, characterizing a person's abstinence from substances as clean. Are you clean today? How much clean time do you have? Versus, are you dirty? No one wants to be called dirty under any circumstances. And when you're really at the lowest of your low, trying to get help and try to move yourself forward, that stigmatizing language really makes it difficult and in fact prevents a lot of people from seeking help. It prevents a lot of families who may not know what to do for a loved one struggling to talk about it with somebody else, because what might they think of me, right, if my child is struggling with substance use? And you get the cascading impact of that kind of stigma.
Like when you're good and when you're bad, kind of.
Exactly.
Yeah.
Exactly. And the language has evolved as we've all tried to do a better job with destigmatizing this condition to allow for more people to hold their head up, make eye contact, and ask for help and get it. And so one example is you've talked about MAT. One of the ways that was characterized for many years was called medication-assisted treatment. And increasingly, we recognize that that language in and of itself is stigmatizing. Are you someone that is in recovery with the assistance of medication, or did you do it the old-fashioned way, right? And no pain, no gain sort of thing. And the reality is we now refer to that as medications for addiction treatment. The outcomes are so much better for folks with chronic alcoholism and opiate use disorder when medications are included for their addiction treatment. In fact, for folks struggling with an opiate use disorder, when medications are not involved in their treatment, the relapse rates are over 90%, as compared to 40% with the addition of medications. And that's just something we had to look at.
So Eric, when you talk about medications, for our listeners, what medications are we talking about here that are available to help folks get the outcomes that you describe and make it a safer and better process for them?
Sure. The FDA has provided bona fide medical indications for a small group of medications. All of those medications fall in the formulary of medications for addiction treatment. And some of them are for opioids, such as heroin, fentanyl, morphine. Some of them are for alcohol, and some of them are for nicotine, right? And so these are the three substances of abuse that have FDA-approved medications for their treatment. For opiates, we would look at methadone, which is the oldest and longest studied medication for addiction treatment for opiate use disorder. We would look at buprenorphine, which many of your listeners might recognize under the name Suboxone, which is really a different medication. It acts slightly differently in the brain and body than methadone, and has very similar purposes to stop preoccupation, craving, and withdrawal so that a person can move forward and attain the skills that are being taught in treatment and essentially maintain their own recovery. And then for alcohol, there are another range of other medications. There's an injectable medication called Vivitrol, which is naloxone that's long-acting, and that actually prevents the euphoria associated with drinking. A person would drink alcohol on that medication and they would not have an effect. That also works the same way for opiates. So Vivitrol is a medication that's been approved for the treatment of both alcoholism and the prevention of opioid relapse. And there are a few other medications out there, but by and large, those represent the most widely prescribed for the conditions we see here in our state.
And now, do all patients who enroll in this program or participate, do they require the use of medications as part of their treatment?
No, and thanks for asking that. We certainly have seen a uptick in the volume of patients that we're treating since we made the changes to the cottage program and became the recovery center. Roughly 70% of our clients that we're treating at any given time have the primary substance problem of alcohol use disorder. Many of them do not elect to seek medications as a part of that treatment, though some do. Ultimately, this is very client or patient driven. We present our clients with a menu of options, including the array of medications, and they make choices about whether or not they want to include those in their care.
That's great. So if we were going to, and I don't know if we'll end with this or not, if you have more, but you touched on the risk factors, and I think for those people listening who might have family members or loved ones that are that they're concerned about, what sort of risk factors might they be looking for?
Well, with all our kids, to start there, certainly a genetic predisposition is an important thing to know about. Is there a family history of substance use disorders of any kind? Is there active use going on? Is there an active substance use disorder or misuse going on in the environment as another risk factor? Individuals may go through life circumstances such as the loss of a spouse, loved one, a death, or some other life transition crisis. Those are times of risk at any age. And so those are the kinds of things that predispose someone, what we call adverse childhood events. So what we find is the increasing prevalence of substance misuse and use disorders when individuals have had significant amounts of trauma in their history.
Okay. And Narcan, do you have, are you working with the YPD on, is that what it's called?
You're referring to Narcan, which is increasingly available here in our state and in this region. Its intent is to be used to reverse an opiate overdose. And there's a very big push on the part of the state of Maine to have a more systematic and orchestrated way of making that vastly more available to our public.
Yep. I think that's a great wrap up and great kind of closing comment. Eric, we can't thank you enough for coming in and talking about the program itself. One last plug. So if you or a loved one feels like they could benefit from your service, you can go ahead and call directly. You can go through your PCP, plenty of opportunities to get into the center through the ER, that sort of thing. We'll put all the phone numbers, contact information in our show notes and have that information available when we broadcast this. But what a fantastic conversation, and certainly more to come, I'm sure.
Thanks very much for having me. I really appreciate it.
Excellent.
Thanks, Eric.
Great. Thank you.
So, Eric, what was your favorite part of that, of the interview with Eric and Dr. Monroe?
So I've known about this program since its inception and have been part of some of the ongoing discussions, have seen patients that I've cared for be referred, but there's always something to learn. And a couple of the highlights to me were related to that window of opportunity when there's a patient that reaches out for help, and that plugging them in quickly increases the likelihood of success in getting through the program. I think that's a great reminder. Also, listening to Dr. Monroe and Eric talk a little bit, I feel like, again, we keep tooting the horn of York Hospital. Even a small community hospital like York Hospital has such a robust recovery program to offer our patients. I think that really is outstanding. What about you? What stuck out in your mind?
I would say going to the supermarket or just being around town and knowing that people around you might be fighting the good fight. And Also, that not everybody coming into the recovery center is using the medication-assisted program, or treatment. So, they are working with people who have all different types of addictions, and
Yeah,
not everyone is using
I think
the
there's some belief out
medication.
there that this can't happen in York, Maine, right? That doesn't happen in our town type
That's
of
right.
thing, and it absolutely does. And to have that resource here again is outstanding.
That reminded me, we had a podcast with Dr. Wilbur
Yep.
a while back, and she was drawn to York Hospital because of the work she wanted to do with Sanford and Biddeford because of low-income people. And it dawned on me, just what you just said, that even an affluent town like York has low-income people. And we have resources here right in the town to serve that population as well. So that kind of just popped up for me.
Yeah, it was really a great conversation and doing really great work. It seems like it is, you watch the news or read the newspaper and you appreciate that this is an ongoing problem that even reaches the ear of our state representatives. Certainly, it's something that is on the forefront of even political discussions nowadays as a problem that this country needs to continue to address and work hard to fix. So we are doing our part here in York,
We
Maine.
certainly are, right here at York Hospital.
Great. Well, thank you for listening to another episode of Seatown. We have some exciting programs coming up. We have Dr. Amanda Dimitri-Lewis, our breast radiologist, to talk about our breast care program. We're going to bring her in. Also, we're going to bring in Katie Dodge and talk about our older adult program.
And patient experiences.
That's right.
Yep.
So be on the lookout for those upcoming podcasts. So thank you again for listening, and we will see you next time.
Thanks, Eric.
All right.
Thank you for listening to this episode of Seatown. We hope you found it of interest and would love to hear from you about topics you'd like to learn more about. Be sure to subscribe wherever you listen to podcasts. You can also find episodes by clicking Seatown button on the homepage of yorkhospital.com. By listening to this podcast, you're agreeing not to use this podcast as medical advice to treat any medical condition in either yourself or others, including but not limited to patients that you are treating. Consult your own provider for any medical issues that you may be having. Seatown is a production of Darcy Creative in collaboration with York Hospital. Copyright 2020.